.id radio voiceover. Hi everyone, welcome to ID Radio, your go-to podcast for the latest research and essential papers on infectious diseases.
Welcome back to the deep dive. Today we're focusing on something that sounds, almost deceptively simple, but it's fundamentally vital to global healthcare. We're talking about the revolution in hand hygiene. This is a deep dive into the last 20 years of the science and the strategy around one single action, cleaning your hands. And despite how simple that sounds, it's just a constant battle for compliance in hospitals everywhere.
It really is. It's the essential invisible armor against infection. And yet, as our source material shows so clearly, healthcare-associated infections, or HAIs, they're still the most prevalent adverse events in clinical care.
And the numbers are huge. We're not talking about a small problem here.
Not at all. The prevalence can be anywhere from, say, 3.5% to 12% in wealthy nations. And in lower-income countries, it can spike to nearly 20%.
Wow. That is a staggering human and economic cost. And it's driven primarily by one thing, transmission, right, via the hands of healthcare workers.
Exactly. So the mission for us today, really, is to track how, since the early 2000s, a dedicated global strategy tried to transform this practice. We're going to explore the science, the logistics, and the behavioral psychology needed to make this simple act universal.
Because right now, the compliance rate is, only about 40% in high-income countries?
That's right, and it gets worse. In low-income countries, it's often below 20%. And you have to understand, that gap between 20% and, 100%, that's a major health crisis right there.
Okay, let's unpack this. To really get the revolution, I think we have to look back at the original resistance. Let's start with the pioneer who first cracked the code.
We have to begin with Ignaz Philipp Semmelweis. He's really seen as the pioneer of the modern era of hand hygiene. His work was back in 1847, so this is long before germ theory was even a thing. He was at the Vienna General Hospital, which had 2 maternity wards.
And he noticed a tragic, just a chilling difference between them.
He did. The maternal mortality rate from what they called puerperal fever was alarmingly high in the clinic staffed by doctors and medical students.
Yeah.
But it was significantly lower in the ward that was staffed only by midwives. He was just haunted by this pattern.
So without the concept of bacteria, how did he even connect the dots?
Well, Semmelweis realized that the doctors and students, they were routinely performing autopsies on women who had died from this fever, and then they would go directly to examine living patients in the maternity ward. He called the infectious material cadaverous particles, and he was right. He hypothesized they were transmitting this deadly material on their hands.
So his intervention was, it sounds brutal, but it was effective. He demanded hand scrubbing with chlorinated lime.
It was a dramatic solution, and it had dramatic results. The mortality rate in that doctor-staffed ward just plummeted. Yeah. But here's the historical tragedy, and it's a really crucial lesson for today. Despite the undeniable evidence, his intervention was just overwhelmingly rejected by his peers.
Why would anyone reject a life-saving practice? What was that resistance rooted in?
The sources point to 3 main barriers, and what's so interesting is how they mirror the challenges we still see. First, the method was just physically damaging. The chlorinated lime caused severe, painful skin irritation. It made continuous practice unbearable.
Okay, so it hurt. That's a huge barrier.
A huge one. Second, Semmelweis himself was apparently, an erratic advocate. It hurt his credibility. But the biggest barrier was the lack of a scientific explanation. He couldn't tell them why these particles were dangerous, only that they were. Without germ theory, the whole idea of invisible killers on their hands just felt insulting to the medical establishment.
So after this incredible, if short-lived breakthrough, we basically saw almost a century of stagnation, just back to basic soap and water. It wasn't until, the late 1990s that things really started to shift again?
That's right. That's when the University of Geneva Hospital stepped in. They recognized the failures of the past weren't about whether it worked, but about the human barriers: time, discomfort, accessibility. So between 95 and 98, they implemented the first really successful multimodal campaign. And the huge turning point was replacing the sink, the soap and water, with alcohol-based hand rub, or ABHR.
And this wasn't just a small improvement. The data that came out of Geneva was the catalyst for global policy change.
The results were just too compelling to ignore. They got a 50% reduction in overall HAI rates, and even more impressively, a 70% reduction in the cross-transmission of MRSA bacteremia. Those numbers proved it. ADHR was the new model.
Okay, so that brings us to what is now the global standard. What specifically makes alcohol-based hand rub such a revolutionary game changer compared to just soap and water?
It really comes down to performance in 2 key areas: the science and maybe more importantly, the logistics. Scientifically, alcohol is just a powerful germicidal agent. It works by denaturing proteins. It essentially dissolves the microbe structure. At concentrations between 60 and 80%, it's incredibly effective. It's fast, and it's fundamental.
But the real victory, especially in a chaotic hospital setting, that seems to be the logistics. It tackles the #1 complaint from healthcare workers.
Absolutely. The single biggest historical barrier to compliance was, and still is, the perception of time constraint. If you use soap and water correctly, you have to walk to the sink, scrub, rinse, dry your hands fully. That takes at least a minute. Now, picture a nurse in an ICU. She might have 100 potential hand hygiene opportunities every single shift. Spending a minute on each one is it's impossible.
So how does ABHR change that whole equation?
ABHR cuts the action time down to just 20 to 30 seconds. That 30 or 40-second time saving multiplied across a busy shift, it's monumental.
Yeah.
And having the dispenser literally at the point of care right next to the patient, it just collapses that time barrier completely.
And we can't forget the skin issue that boomed Semmelweis. I mean, if you're washing your hands 100 times a shift, soap and water would destroy your skin.
That's right. Modern ABHR formulations are significantly less damaging, especially when they include emollients, like the glycerol in the WHO formulations. It solved that physical pain point that sunk the whole effort in the 19th century.
Okay, so we've established it's faster, more accessible, easier on the skin, and it kills bacteria and enveloped viruses, including SARS-CoV-2. But what are the limits? When is ADHR not the better option?
And this is the crucial nuance. While alcohol is devastating to bacteria and viruses, it generally cannot eliminate spores. So if a healthcare worker's hands are visibly soiled, or if they're dealing with a spore-forming organism like Clostridioides difficile vas C differently, then hand washing with soap and water is still the required method to physically remove those spores.
But outside of those specific cases, the way alcohol works is so disruptive that we don't really have to worry about pathogens developing resistance like we do with antibiotics.
Correct. Pathogens don't develop resistance to it because the mechanism protein denaturation is a direct physical destruction. It's not something a microbe can biologically learn to fight.
That's a powerful tool. But moving from one hospital in Geneva to rolling this out globally, we're talking 192 countries, that takes more than just a good gel dispenser. It needs a massive plan to change behavior.
It takes the World Health Organization's multimodal strategy. The framework is built on 5 interlocking components because you can't just mandate a new product and expect things to change.
Okay, let's start with the foundation. Pillar 1, system change.
This is purely logistical. It's about creating an infrastructure where the right materials are available, without effort. It means ensuring ABHR is located exactly at the point of care. If a healthcare worker has to take 3 extra steps to sanitize, those 3 steps are a barrier.
Pillar 2 is education and training. I'm guessing this is more than just wash your hands posters.
Oh, absolutely. These are highly standardized programs, often using a train-the-trainer model. The goal is to make sure healthcare workers know not just how to rub their hands, but critically, when to do it. And that's all guided by the My 5 Moments for Hand Hygiene framework.
We hear those 5 moments mentioned all the time in the sources. For anyone who isn't a specialist, what does that mean?
The 5 moments are the critical times when hand hygiene has to be done to stop cross-transmission. They are 1, before touching a patient, 2, before a clean procedure, 3, after a risk of body fluid exposure, 4, after touching a patient, and 5, after touching the patient's surroundings. It's a very specific choreography.
Which leads to pillar 3, evaluation and feedback. This has to be the hardest part, right? Because accurately monitoring human behavior is famously difficult.
It's filled with challenges. Direct observation is technically the gold standard, but it immediately creates the Hawthorne effect.
Remind us what the Hawthorne effect means in this context.
It's that psychological phenomenon where people change their behavior just because they know they're being watched. So an auditor is standing there, the worker might be 95% compliant. The second the auditor leaves, those rates can drop by half. It means our official records are almost always inflated, which hides the real problem.
So what are the alternatives to get around that?
Electronic monitoring is highly precise and gets rid of the Hawthorne effect, but it's expensive. A cheaper surrogate is just consumption data measuring how many liters of ABHR are used. But that doesn't track the 2 most important things, technique and timing. Was it used at one of the 5 moments? You just don't know.
And when you get that data, how do you feed it back effectively?
Feedback works best when it's immediate, non-punitive, and individualized. And the research warns against setting unrealistic goals, like demanding 90 or 100% compliance right away. That tends to demotivate people.
Right. Okay, pillar 4. Reminders in the workplace. The signs, the posters, the nudges.
Reminders are vital. They use visual or auditory cues to cut through the information overload in a busy hospital. But there's a fascinating paradox here. The sources note that constantly changing the posters or just bombarding staff with reminders can actually lead to lower compliance because of habituation. The brain just tunes it out.
And finally, pillar 5. Institutional safety climate. This sounds like it's about culture and leadership.
It is. It's the cultural core. Leadership has to set the example. This pillar also pushes for empowering patients to ask their healthcare workers, have you cleaned your hands?
That sounds powerful, but is it realistic?
In practice, it's very difficult. Studies show both patients and staff feel extremely uncomfortable in that situation. Patients worry about challenging authority, and workers can feel distrusted. The social barriers are very high.
Okay, here's where it gets really interesting. We've talked about the when and the what. Let's talk about the how, the technique itself. The global standard is the WHO 6-step technique.
Right, that's the official gold standard. A sequence of rubbing palm to palm, back of hands, interlacing fingers, and so on. It's designed for full coverage over 20 to 30 seconds. But the research quickly showed that most healthcare workers, even highly trained ones, just don't complete all 6 steps perfectly.
Which led researchers to test simplification. If perfect isn't possible, what's the next best thing?
Exactly. One major trial compared the standard 6-step technique to a much simpler 3-step one. The results were astounding. The simpler method led to a huge increase in compliance. It jumped from about 13% to over 51%. Technique compliance also went up.
That's incredible. An easier, faster method gets you 4 times the compliance. And the bacterial reduction was basically the same.
It was. And other research looked at a fingertips first technique because fingertips are a huge risk for cross-transmission. That modified technique actually showed greater bacterial reduction than the standard 6 steps in some tests.
So this creates a fascinating policy paradox. The data says simpler is better for compliance and just as effective, if not more so. Yet, the complex 6-step standard is still the global rule. Why does complexity win out over compliance data?
That inertia is a mix of bureaucracy, tradition, and just the sheer difficulty of changing a global standard once it's in training manuals in 192 countries. It really highlights a major research gap. We have to prioritize high compliance over high complexity.
And beyond technique, what are the other stubborn barriers that even this revolution hasn't fully solved?
2 really stand out. First, staff category. Studies consistently show that doctors tend to be significantly less compliant than nurses. The reasons are complex, but it's a persistent gap.
And the second one?
The misuse of gloves. There's this false sense of security that wearing gloves is a substitute for hand hygiene, but it's not. Workers might not clean their hands before putting gloves on, or worse, they'll contaminate your hands when taking them off and then not sanitize. It's a huge problem.
And then, of course, in the middle of this whole 20-year effort, an event happened that forced the entire world to focus on hand hygiene like never before, the COVID-19 pandemic.
The pandemic was the ultimate wake-up call. The data shows a massive spike in hand hygiene research. ABHR was absolutely critical against SARS-CoV-2. And the sudden, immense global demand caused these abrupt supply shortages.
Which led to a really interesting, life-saving, decentralized solution.
Yes. The crisis triggered this wave of local production of the WHO-recommended formulations. Simple, effective, inexpensive recipes. It proved the policy could adapt fast. But that had a downside too.
Quality control.
Absolutely. The crisis led to an alarming flood of low-quality, subpotent, or just improperly formulated hand rubs hitting the market. The need for quality assurance became paramount.
So after 2 decades of this strategy, the power of ABHR, and a global pandemic to focus the mind, what's the final verdict on the revolution?
The progress is undeniable. Campaigns like WU Save Lives, Clean Your Hands have fundamentally transformed the culture. We've solved more than half of the research questions posed 20 years ago.
But the compliance rates are still sitting at 40% or less. The remaining challenges must be incredibly complex.
They are. The sources list 55 new proposals for future research, focusing on things like resource-poor settings, new educational models, and breaking those behavioral barriers we talked about.
So what does this all mean? If the behavioral part is so hard to lock down, where should the focus be next to finally bridge that gap?
Well, the next frontier isn't just about behavior anymore. It's about precision science connecting the practice to actual patient outcomes. We need to bridge the gap between compliance data and patient safety itself.
That's a provocative thought. You mean connecting the number of hand rubs directly to a drop in infection rates on that specific ward?
Precisely. The key unanswered question is this. What is the minimal level of microbial pathogen reduction on a healthcare worker's hands that is required to actually ensure patient safety? If we can scientifically define safe enough, we can tailor our efforts much more realistically. And at the same time, we have to fight the infodemic, the flood of misinformation about ABHR that actively undermines its use. We can't let scientific progress get eroded by anti-science noise.
That is the ultimate challenge. We know the best way to clean hands, but the future of safety relies on figuring out exactly how clean is safe enough and then making sure that fact wins out. ID Radio voiceover. Thanks for watching. Please make sure to like, share, and subscribe to ID Radio.